I'm David Adams. It's my great pleasure to welcome you to the 5th ATS Mitral Conclave.
I'm Dr. Randy Martin, and I'm thrilled to be joined by my good friend, Dr. Tirone David. Tirone, good to see you again, as always. So interesting comments this morning in a talk about the future of mitral valve surgery, that 3/4 of it might be transcatheter. You've been the master at tracking outcomes. Outcomes are critical.
I'm concerned about this trend that less invasive is better. Better for what? Better for whom? We have to put the patient in the center of the whole thing. If it's better for the patient, I'm all for it.
Right.
So I think more careful follow-up and examination of the outcomes is needed before we keep jumping ahead for technology. It's very nice and wonderful to develop a new gadget,
right,
but is it better than what we do now in the short and long term? The first problem is mortality. If you can bring mortality down to the same level as surgery, that's the first hurdle that you have to pass. But depending on the patient's age, you have to be very careful about what's going to happen next 2, 5, and 20, 30 years later.
Correct.
And that's where I think the problem might become even more serious.
Well, you've done, obviously you've had great 20-year data out. I know you've extended that.
Well, the problem with longitudinal outcomes is the moment you pass 20 years, the sample size shrinks dramatically because the average patient is 60, 65, and not all of us live to be 90 or 100. So we start with a 1,500 patient, age 60, only half of them make to 80. So the sample size shrinks dramatically, and but the outcomes of mitral valve repair for degenerative disease is going to be very hard to beat. What we're discovering, however, by looking at them at 30 years later, the new problems appears. And we don't know if the new problems are related to the timing of surgery. In other words, you as a cardiologist sending the patient a bit too late.
Too late, correct.
Like I was shocked in our last examination, which is submitted to Jack, hopefully it will be printed, the incidence of atrial fibrillation. Half the patients 25 years later are fibrillating.
Big atrium.
Absolutely. When I look back, why? It's not ventricular function. Ventricular function was normal, but the atrium was 55 millimeters by the time I operated on them.
Absolutely.
Perhaps it's too late. Yeah. Perhaps if the operation is so safe, or perhaps a percutaneous intervention is so safe, we're going to have to be much proactive and treat the patient before the myocardium, both sides of the myocardium, the ventricle and the atria, become abnormal.
Is it hard for people to do outcome? I mean, you've had a phenomenal outcome basis because of your population, but outcome's really important.
I think it's difficult in your system. The American system is much more different than Canadian. Having a single payer for the health care, no matter where the patient goes for a test, it is within the system. And one way or the other can find the outcome. You can find the result, the test, the CAT scan, the echocardiogram. In my area, it's mostly echocardiogram. And although you might question the quality of the echocardiogram done peripherally, you can always request the films, the images, and give it to your cardiologist to review if it's not clear. So it provides a great opportunity to look at patients several decades later.
So if there's a tremendous enthusiasm for transcatheter techniques among the young surgeons, the young interventionalists, and generally the field, how do you measure? I mean, how do you compare that to surgery with outcomes? In other words, what I'm worried about is there are less and less surgery and more of this. So you just have to follow it with the same.
It is a problem. That's why I think like a government, unfortunately, have to step in. people control the healthcare and they should step in. I don't think it should be only economically driven.
Right.
And I mean, the profitability of percutaneous technology is unbelievable for the companies that produce the device. Mind you, it costs them a lot of money in R&D, and they want to recoup the money now. But that's a very expensive type of technology, which is fine. And I think that's how we should go. It is better for the patient. Not only, again, as I said before, perioperatively, but 5 and 10 years later. Let's see what's going to happen to when a TAVI starts failing now, and the patient might have to come back for a second procedure. The few I have taken it out is not a minor operation. It requires a very experienced aortic surgeon to take a core valve 5 years later, because the whole root becomes abnormal. Can the average surgeon do this operation? In other words, what we gain early in the first 2, 3, 5 years, we might lose 5 years later. And then the result might be a -1. So we have to keep things in perspective for now.
Well, I mean, it's critical. I mean, I think the outcome data is really the proof of the goodness of the technology, or their limitations of the technology. Listen, you've been a strong advocate of excellence.
Yeah, well, my whole lifetime
comment?
been looking for the right answers. But it's interesting. I just wonder what would have happened to healthcare in my lifetime. I mean, practiced for 40 years. If we have spent as much money investigating the device to correct the pathological process, and instead had invested this money in find why we became sick, why the disease process developed, and eliminate the disease process. Surgery is therapy. Percutaneous device is a form of therapy. But why don't we fix the underlying cause and everything disappears? In other words, go back to the internist. Really, surgery is a very small portion of medicine. It's a type of treatment for disease that we cannot treat with pharmaceuticals or eliminate the cause of the process.
Genetics?
Genetics, absolutely.
Absolutely. Listen, thank you. Thanks for joining us. Thanks very
Pleasure.
much. It's always good. I'll shake your hand. Thank you. And thank you for joining us.